Hello, everyone. Welcome to the next segment in Fluorescein Angiography. We've looked at some of its aspects in the previous series, and now we look at Fluorescein Angiography and its role in choroidal, RP, deeper pathologies, and of course, a lot of miscellaneous macular pathologies. Choroidal neovascular membrane is one of the most common entities that we look at with fluorescein angiography. CNVM is basically a neovascular complex that extends from the choriocapillaries and comes in through the Brooks membrane into either the sub-RP space, and we call it the type 1 CNVM, or it comes into the subretinal space and we call it the type 2 CNVM. In diseases where Brooks membrane RP function has been compromised, basically, the common causes are degenerative, traumatic, inflammatory, or neoplastic. The most common association is age-related macular degeneration or with myopic degeneration. So when we look at the types of CNVM on the fluorescein angiography, they are also classified as a classic and an occult membrane. Nowadays, we use multimodal imaging, so it's not just fluorescein. The OCT becomes a mainstay for us to look at any fluid as well as look at its location. But an occult lesion basically lies in the sub-RP plane, and fluorescein patterns are typically seen in the late phases. The type 1 choroidal neovascular membrane, you can see here again, you see the classic membrane which starts fluorescing in the center, and then the diffuse leakage where the limits of the membrane cannot be defined because the leakage is so intense that the margins become totally diffused. Here you see an OCTA also taken, which shows you a nice network which confirms the presence of a neovascular activity. And so OCTA is also now used to replace fluorescein angiography in some of these situations when we are looking at baseline and then treatment, post-treatment, the regressions. The type 2 choroidal neovascularization, which is subsensory, it lies above the RP, and you can see the classic lining of the blood around it, which shows you activity. If you do an OCT, you'll see fluid and a classic membrane, which is actively leaking. And when you look at fluorescein, you see the lacy hyperfluorescent pattern, which is classic of this particular pathology, and the venous phase intense hyperfluorescence leakage and the late persistent staining which happens with this type of a membrane. Then there can be a juxtapapillary membrane. You can see that as the phase progresses, you'll see the margins of the membrane coming up and the mass fluorescence of the hemorrhage, which is there in the surrounding area. And you can basically always correlate it clinically with the presence of blood and the presence of where the membrane is in relation to the fluorescein angiography that you see. So here you see the early hyperfluorescence where the membrane pops out within the whole framework of the blood, which is blocking and masking some of the view. And in the late phase, you can see how well this whole leakage intensifies, and then you can see the margins surrounded by the blood around it, and confirms that there is a membrane underlying. The fuzzy hyperfluorescence with the indistinct boundaries in the later phases. Briefly, just wanted to tell you about ICG angiography because I just want to show you where we use that apart from fluorescein angiography. So the ICG is a water-soluble dye and is stimulated at about 790 and 805 nanometers, and then there's a barrier filter at 835. So in this spectrum of infrared light works and is stimulated, and then it comes out and is taken by the cameras. And nowadays we do the same as with the SLO-based cameras using the laser beams instead of using the filters for the ICG. So when we look at ICG, it brings out much better choroidal fluorescence because it's 98% protein bound, and so it stays within the choriocapillaries, and it shows you very intently the fluorescence which comes with this particular dye. So it's a deeper penetration of the dye due to the long wavelength and its protein-bound nature. It has the potential to identify the CNVM hidden by the subretinal hemorrhage and exudation. So here you see a hot spot. We define it as a hot spot or a leak. So amongst the surrounding blood, which is blocking fluorescence, the ICG can penetrate and show you hot spots of activity underlying, which the fluorescein sometimes cannot do. So we typically do a fluorescein on the ICG together. On the left is the fluorescein frame, and on the right is a simultaneous ICG frame. And if you look at the early phase, you'll start seeing this particular area where a hot spot or a feeding vessel is trying to come up in cases where fluorescein will not show you much because it gets blocked by the blood over it. This is another example. You look at this particular channel here. In the first 8 to 10 seconds of the dye injection, you'll start seeing these channels, which are the feeding vessels for a neovascular membrane. In the past, we used to use this a lot in the era before anti-VEGFs because if we found a feeder vessel which disappears very soon, within 20 seconds, it will merge with the rest of the choriocapillaries. If the feeder vessel is outside of the foveal area, we would go ahead and laser it, and that would help regress the membrane. But today, of course, its usage has become less because of the presence of anti-VEGFs that we have. Then there's idiopathic polypoidal choroidal vasculopathy, IPCV as we call it. It's got branching vascular network of inner choroidal vessels, multiple terminal polypoidal proliferations, protuberances which are there, and they lead to extensive serosanguinous fluid, blood, and deposits of exudation, which happens and brings in a lot of visual debilitation for the patients. PEDs, also notched ones. This is another example of a large collection of blood in such a situation. You do a fluorescein and an ICG, and you can see a hot spot coming up within that whole framework of the subretinal blood, and grape-like lesions, polyps at times are seen much better on the ICG. This is another example of a grape-like cluster which comes up, the polypoidal network, which is seen on the ICG. Fluorescein, you can see that there's a total dark spot, while on the ICG you see various areas which are fluorescing because of its ICG's ability to penetrate through the blood and shows you the polypoidal changes. This is again a network seen on the ICG of this grape-like clusters here, while the FA will show you a more diffuse, barely fluorescent area, while here you see a whole network of grape-like clusters, which tell you that this is IPCV or a polypoidal network. Then there's pigment epithelial detachment, where there's the pooling of the dye which happens on the fluorescein. You can see that there's an intensity increase, but the margins will not change or become fuzzy because it's a closed RP space, a convex space which does not change, and this is where the pooling comes up. Now, PDs can be serous, fibrovascular, drusenoid, or hemorrhagic. This is a serous PD. You can see it's a fluid-based serous collection, which is seen typically on the as a pooling. Then there is a drusenoid PD, which will have the early diffuse hyperfluorescence with faint hyperfluorescence progressing to irregular staining. It will not take that classic convex shape, but would take an irregular type of fluorescence pattern which come out. The hemorrhagic PD may not show you a lot of fluorescence because it's filled with something with a hemorrhage inside, and the pooling will not be seen as easily. And you correlate it clinically, and nowadays with OCTs, you can make out the exact situation. Then there's retinal angiomatous proliferation or a RAP lesion that we call it. You can see the early formation of a retinochoroidal anastomosis here in the deep retinal plexus. You see hemorrhages within the choroid, and this is how it might look like on an OCT with elevated PED-like structures. And when you do the angiography, you will see the faint hyperfluorescence from a small front of intraretinal neovascularization within that complex. Perfusing retinal arteriole and draining venule may be also appreciated or seen in these cases. So the diagnostic in most is the hotspot in the mid or late frames, which comes up in the middle of the lesion, seen quite classically. Then there's the Doyne honeycomb retinal dystrophy, where you see this either a cuticular drusen phenomenon and a fluorescein angiography showing you hyperfluorescent spots or a stars in the sky appearance which takes place. Then a rip or a RP tear, we call it, occurs at the junction of the attached RP and the pigment epithelial detachment. the two opposing forces, traction from the CNVM contraction, sometimes due to an anti-VEGF given or sometimes just spontaneously, and the adhesive force from the attached RPE. The tear usually appears on the opposite side of the neovascular membrane. Contracted RPE monolayer comes to rest on one side of the CNVM. This is an example of an RP tear. You can see this whole expanse seen very well on the fluorescein angiography. You can see that the intensity increases, but the margins don't change because that's where the rib has retracted, and you can see the choroidal flush coming up in that. The RP is missing in that area. The OCT picture confirms exactly where the rib has happened and where that you are seeing, from where you are seeing the choroidal hyperfluorescence of the RP window defect. Then there's tenofovir toxicity. We saw this as a window defect in our earlier series talk as well. And I'll not go into the details, but you may see the stippling pattern of the RP that is seen in these patients. When they are on long-term tenofovir, they show pigmentary alterations, and the photoreceptor damage on the OCT is seen and correlated quite well. So we always use multimodal imaging to define these kind of entities. Once you do the FFA, you'll see something much more starkly apparent as something like this. You can see both eyes symmetrical pigmentary changes. So I'll just go back to what you see clinically. There's a subtle change which is happening in the pigmentary areas on clinically on the infrared images and on the OCT, and look at the FA where you see a much more aggravated picture of the same entity, which shows you an outer retinal and a photoreceptor damage from this use. Then we come to macular telangiectasia, MACTEL1, which may be unilateral. The fluorescein angiography highlighted dilated and tortuous aneurysmal perifoveal capillaries, that network that you see here, mainly involving the infratemporal macula. So this is the type 1 aneurysmal and telangiectasia surrounded by a ring of aneurysms, exudates, which are seen around the aneurysm. Early phase showing microaneurysms temporal to the fovea, and then the late phase, the same area would get much more diffuse hyperfluorescence. The type 2 is a bilateral classic disease. You can see a slightly grayish coloration of the macula, more apparent on the temporal side, and you may see sometimes pigmentary changes or hemorrhages in that area clinically. When you do the FA, you may see dilated ectatic perifoveal capillaries at right angle venules showing late leakage on the temporal side of the fovea. Sometimes there's an SRNVM, and you can have a classic membrane coming up alongside as well. This is again bilateral MACTEL type 2. You can see this grayish concentric area on the macula clinically, bilaterally symmetrical that you see in this area. And correspondingly, you may see some changes on the temporal aspect of the foveal area. When you do the fluorescein angiography, you see something like a cystoid macular edema, but it's very symmetrical in these areas, and you correlate it clinically. And as the phase progresses, you'll see early changes happening on the temporal side of the fovea, and then it becomes more concentric there. Central serous chorioretinopathy, CSR, we encounter it a lot in the young patients that come to us. Localized serous fluid collection in the macula. And this is how it looks like, a convex, very well demarcated area that comes up with a patient complaining of a recent decrease in vision centrally. You may see an ink blot or a smokestack leak, which is typical of these areas. On the OCT, you'll see a subserous fluid collection evenly, and sometimes you may see PEDs underlying that. So ink blot pattern, you can see at the beginning of the angiogram, you might see a small focal leak source, a small ink blot, which is going to increase as the phase progresses. You can see that it concentrically increases in intensity as well as size, and it keeps on increasing up to a certain phase, which confirms that this is a ink blot CSR leak. This is a smokestack leak. You can see it goes up and then diffuses, and we are doing a simultaneous OCT multimodal imaging, and you can see sometimes a PED in relation to near the areas of the leak. You can see here a small PED which comes up also. So here again, you see a smokestack. It's a leak which is starting below the fovea and then finds its way around temporally and goes up and expands a typical smokestack. There's another case example, OCT showing you a CSR, and then when you do the fluorescein, a smokestack leak gradually increases almost at the foveal area. This is another example of same. So these define the site of leak, and we do angiography nowadays in CSR only if it is not resolving, not to really confirm the diagnosis because the OCT helps us non-invasively do that. But if the leak is not resolving, if the fluid is not resolving beyond a few months, then we like to do an angiography to establish, confirm the diagnosis. And at times, if the leak is extrafoveal, we can do a mild laser to it and treat the condition. In fact, at times you do a laser. This is a classic case of a patient. If you look here on the left side here, we've done a mild laser to that area, and the patient's leak disappeared, but came back after 6 months, and started to form a visual loss at that particular time. And the site of leak might have disturbed the Brooks membrane, and now you see a small membrane has come up and is showing a leak. So sometimes a CSR patient comes back, it may not be a recurrence. You look carefully, it may be the site of a SRNVM which has started from alongside a previous leak site, or if you have lasered, then it could be related to the laser rupturing the Brooks membrane. So it is sometimes a complication. So if you can see that this patient came back, we suggested giving anti-VEGFs, but the patient was reluctant and waited, and you can see that how the SRNVM increased. And these are angiograms done over a period of time that you can confirm that this is a post-CSR CNVM forming and causing a lot of damage. Then there is multifocal CSR, which is a different entity, which sometimes happens with the steroid use. In some patients, at times it's linked to some tubercular protein also. So here you will see random multiple sites of leaks, and clinically, of course, the patient has these elevations, serosanguinous, serous elevations. Sometimes you have to differentiate it from a VKH condition, and the angiography helps us do that very clearly. This is classic of a multifocal CSR, very different from what you see on the VKH. This is again the same patient's more wider pictures, and this patient was on steroids for a condition, and we asked the patient to stop the steroids, and eventually the leaks disappeared. Chronic CSRs will show you multiple pigmentary changes, sometimes tracts going down from the macula to the lower area gravitationally. Fluid has collected over a period of time and then dissipated to different areas, leaving pigmentary changes. These patients have chronic visual loss at times. You have to keep on seeing them. Sometimes they respond to anti-VEGFs. Sometimes they respond to PDTs. A lot of treatments are done for these type of patients. Optic disc pit maculopathy. Uh, Nowadays, we use OCT to document it, confirm it, and also see the amount of schisis or if there's a presence of a macular hole or any other thing alongside. But the fluorescein angiography might just give you a subtle hue of hyperfluorescence near the area of the pit and the area of the macular thinning. But otherwise, OCT is a better tool to define optic disc pit and maculopathy. Vitelliform macular dystrophy, blocked fluorescence due to the vitelliform deposit, late ring staining of the lesion can happen like what you see here. At times, these can form SRNVMs and can also show you more changes on the angiogram, but otherwise, these are the type of changes that you see. Stargardt's disease, heredomacular diseases, again, autofluorescence or infrared imaging is good enough to document, and OCT tells you a lot about the thinning or the thickness of the macula. Fluorescein angiography is no more required to diagnose them. They may be used if you're suspecting something else alongside, but otherwise, most of the times we use OCTs and infrared imaging or autofluorescence for these cases. But of course, IFA will show you small window defects due to the pigmentary mottling that is happening in these cases. Dome-shaped maculopathy, a rare condition, but comes up in myopes, may represent a type of a localized staphyloma. like lesion which is there, but a dome shape. Serous macular detachment is often found alongside, and angiogram may show you mottle areas which are there, and it doesn't have a specific treatment as yet, but anti-VEGFs have been used in some situations. Now we come to choroidal and retinal inflammations, non-infectious or infectious type. We come to serpiginous choroiditis. This is a grayish yellow subretinal lesion that you see which come up contiguously. Peripapillary centrifugal spread is there in a serpentine fashion. You may see scarring in some areas and active areas in the margins. And OCT is done to look at some of these changes, and of course, fluorescein angiography. Before you do that, fluorescein autofluorescence may also define some sort of margins of activity as well as non-activity. And the fluorescein characteristic of the active lesion is that early hypofluorescence that will always be seen with an active lesion, and late hypofluorescence staining the margins, or capillary dropouts at times might be seen, and blockage due to the inflammation might be seen. So these are progressive for pictures of angiography as you go from hypo to active margins to hyperfluorescence in the late phase of those margins suggesting activity. The macular variant of the serpiginous choroiditis starts at the central macula. Early intervention is vital to prevent irreversible central loss. This is what you see on the angiography on the right, that you see how, again, a early hypo followed by a late hyper on the margins. Acute posterior multifocal placoid pigment epitheliopathy, APMPP, bilateral idiopathic inflammation at the level of choriocapillaries causes hypoperfusion and ischemia of the RP in photoreceptors. Multiple large yellow white placoid lesions on the posterior pole fade within weeks with RP disruption of various levels. And you can see here fluorescein on the left and ICG on the right. And you can see the ICG will give you much better definition here. They are deeper, the involvement. And so you see hypofluorescent type of patches on the ICG, which you see, and a hot disc on the FA, which is typical of an activity of these lesions. So hypocyanescence seen, giving you the margins of how the extent of these lesions which are there. Multifocal choroiditis, again, you see different patches. They are not connected like the serpiginoid type of them. Bilateral asymmetric inflammation characterized by the yellow-gray active lesions and punched out atrophic scars. Once again, on the FA, you will see all those lesions much better defined with early hypo and a late hyper on the FA, and the ICG will show you these dark areas suggesting that there is activity to these areas. Then there is azure acute zonal occult outer retinopathy. It's a rare condition characterized by the acute onset of visual field loss, often temporal, in young or middle-aged females, and may follow a viral prodrome. Rapid zonal field loss not consistent with near normal fundus findings at the onset of disease would be there, but you do an FA and you can see the margins much better defined. The zonal peripapillary hyperfluorescence due to the window defect and the staining, and this can progress over a period of the years on follow-up. Then there's acute retinal pigment epithelitis, ARPE, krill disease, rare idiopathic unilateral self-limited condition of the RP. You can see disruption of the ISOS band and a thickened RP on the OCT. And the fluorescein will show you early hypofluorescence with an hyperfluorescent halo, which is there alongside. The late phase staining without any leakage can be appreciated in these cases in the macular area. Posterior nodular scleritis, you can see here there is an elevation around the peripapillary area, a lot of fluid collection on the macula. You see an OCT with the elevation coming from the scleral choroidal complex. Early heterogeneous hypofluorescence due to blocked choroidal circulation, and as the phase progresses, you see a hot disc with patchy hyperfluorescence. Progressive pinpoint areas also with late leakage are seen in this kind of a condition. I was mentioning VKH, Woko, and Agi Harada in relation to the multifocal CSR. Sometimes the clinical picture is bilateral and you may confuse it with that. While in the VKH, you'll see these, instead of what you saw with the multifocal CSR, lot of leaks. Here you'll see very small pinpoint type of leaks seen irregularly in the areas when the FA is done in the arteriovenous phase. As the phase progresses, the intensity of those may increase, but they never reach the level of the type of multifocal CSR that you see. The importance to distinguish it is much more, because in Vokanagi Harada, you need to give the patient high dose steroids, while if it's a multifocal CSR, you may be dealing with a patient who's sensitive to steroids and you need to actually stop the steroids. So these are the phases of the VKH that you see here: early hypo, late hyper with pinpoint type of lesions seen on the FA. While if you do the ICG, you'll see these darkish patches in all those areas affected, much better seen on the ICG than on the fluorescein at times. This is OCT, of course, because we do multimodal imaging. You can see on the OCT the changes that are happening on Woko and Age Harada. Again, the FA and the ICG early phase, and then the late phase, you can see the hot disk on the FA, while on the ICG, what is more prominent are the dots, the black dots, hypofluorescent, hyposcyanescent dots that are seen in these. Then we come to CMV retinitis. You see the pizza ketchup-like appearance. You see inflammation going from the disc to with the vessels. You see the OCT changes with sensory retina being affected. And the fluorescein, of course, will show you partly masking and no specific lesion related to it, but you are correlating the features of what you see clinically on this in this hypofluorescence with the retinal whitening, necrosis, and an overlying hemorrhage which is there. The late staining takes place with the hot disk because of the inflammation and leakage from the retinal vessels. Serpigenoid choroiditis, bilateral chronic recurrent centrifugally spreading pattern serpigenoid, non-contiguous to the optic disc. The choroiditis that tracks retinal vessels may have reasonable specificity of tuberculosis at times. So here you see the early, mid, and late phase quite well defined margin seen on the FA that you see here, and the ICG on the side, which is showing you hyposcyanescent lesions in the same category. So to determine if the choroiditis is active and to confirm pre-retinal neovascularization and demonstrate any ischemia, we see early hypofluorescence and late hyper on the FA, and the lesions remain hypofluorescent or hyposcyanescent in ICG. Also, when you do the ICG, when you do an OCTA, you may see similar changes to ICG. You'll see these dark patches on the OCTA in the area which is affected, exactly similar to what you see on the ICG. These lesions respond dramatically to combined antitubercular and steroid treatments. Then there's retinal vasculitis, and at times Eales disease, when we can't find a cause, they cause sheathing and a lot of hemorrhages and exudation and capillary non-perfusion areas at times, eventually leading to tractional detachments, hemorrhages, and a lot of visual loss for these patients. So it's best to identify them at the earliest, and then start to treat them. We always have to reduce inflammation. In these cases, steroids work to reduce inflammation, but to do more finite treatments, you need to document angiographically any CNP areas, any neovascular areas, and treat all those lesions with lasers so that no neovascularization happens in these patients. And in the acute phase, you give steroids, but as soon as you have a cover of steroids, look for any CNP areas and reduce the chances of long-term debilitation due to neovascularization and neovascular glaucomas and a lot of other entities by doing a good laser. Also use anti-VEGFs when required in these cases when they reach the stage of neovascularization. This is occlusive tuberculosis leading to periphlebitis, inferior branch retinal vein occlusion you can see here due to the occlusion, and the angiography is showing you areas of mass fluorescence due to the hemorrhages, and of course the vascular network which is seen, which has got inflammation in that area, and you can see the whole area which is flaring up the fluorescence. Toxoplasma retinochoroiditis, classic lesions. You'll see old lesion with dark pigmented patches, and alongside you may see active lesions which are causing a recent decrease in vision. They cause extensive atrophy of that area, thinning of the sensory retina, and at times you'll see a lot of cells in the vitreous if there's an active area over those lesions on the retina. When you do a fluorescein angiography, there will be an early hypofluorescence due to the retinal edema and necrosis with progressive leakage from all satellite active lesions which might be there. They need to be given a full course of anti-toxoplasma, and once they are near the macula, you should always give steroids. We at times also add Ozurdex if there is a macular involvement alongside giving anti-toxo regime. Here you see an atrophic punched out toxoplasma scar, which has led to the formation of a secondary subretinal membrane, neovascular membrane. So this is another entity which can form subretinal membranes on the borders of these scars because of break in the Brooks membrane. And so they need to be treated with anti-VEGFs because the toxoplasma lesion is inactive, but the activity is coming because of the membrane which has formed in this area. You can see here how the phase progresses and the activity is seen much better. Acute syphilitic posterior placoid chorioretinopathy. So here you see large, pale, yellowish subretinal placoid lesions at the posterior pole. Clinically, you see a ground glass appearance of the retinitis occur during the secondary syphilis. So here you see progressive late phase hyperfluorescence and diffuse staining of the placoid lesion and disc inflammation at the level of RP and the choriocapillaries. So once you see here early venous phase of the fluorescein on the left, and on the right you see ICG. Here the fluorescein is giving you much more information of the area which is affected and the leakage and the staining and the hot disc which is seen quite apparent in comparison to the ICG, which is of course looking quite quiescent and dormant in this particular area. Post-fever retinitis, many viral fevers can end up with something like this. You see a swollen disc and exudation alongside the OCG. OCT gives you some fluid collection with the peripapillary edema, which is seen apparently, and you do the angiogram and you'll see the localized inflammation standing out with hyperfluorescent and a hot disc, which is seen in the late phases. This again post-fever retinitis and vasculitis. You can see the hemorrhages which are scattered in up to the periphery in wide field imaging, and the cotton wool-like lesions, patches with sensory retina edema seen on the OCT. Can you imagine this patient when you do the angiogram is extensive CNP area, totally a loss of capillary network which is seen in this. So here there's a dramatic appearance of the fluorescein angiography giving you a reason for why the vision would suddenly drop in these patients. This is again other eye of the patient. You can see that what is happening. Total loss of the fuzzy perivascular leakage and a hot disc, but there's hardly any capillary network seen from the choroidal complexes here. Now coming to choroidal tumors, tumors are a totally different entity, and they need multimodal imaging. There is no one particular test which is confirmatory. You need to correlate clinically what you see, the history of the patient, age of the patient, the shape of the lesion. OCT tells you a little bit just to document how the macula is involved. And when you do the fluorescein angiography, you will see ultrasound is very diagnostic. Fluorescein angiography helps you look at the circulation. Fluorescein ultrasound guides you much more in terms of the reflectivity of the lesion and the convexity of the lesion, in this case, a melanoma. And you see a mottled fluorescence in the arteriovenous phase and the late diffuse leakage and staining happening in this case. Most common findings could be intrinsic dual circulation, which is mentioned here. So here you see a phase which is actively progressing, an angiogram, fluorescein dye is injected, and you can see how the area of the tumor is defined in relation to the rest of the retina, and patchy hypofluorescence due to the areas of subretinal hemorrhage and a lipofuscin deposition takes place in the early venous phase, and an intrinsic double circulation, which is basically a patchy hypofluorescence from the tumor's own blood vessels in the late venous phase. Late staining of the lesion plus multiple pinpoint hotspots of leakage at the RP level are seen at this joint. Then you come to choroidal hemangioma, which has a much more uniform conglomeration of the arteriovenous network, which is growing here. It's a circumscribed choroidal hemangioma. It's usually orangish in color, hue, clinically diagnosed. And when you do a fluorescein, you might see early spotty hyperfluorescence with late diffuse intense hyperfluorescence. When you do an ICG, you see a rapid hypercyanescence of the tumor vessels, and the rapid clearing is a dye washout phenomenon because of the circulation, which is quite extensive in this particular type of tumor. When you look at a metastasis, it's a much more flatter region. It may be more than one. It may be wider, but more flatter as compared to a hemangioma, or a melanoma at times. And you need to correlate clinically. Here, hemangioma can lead to a lot of fluid exudation, and here you see elevated macula because of that. And when you do an angiogram, you may see early hypofluorescence and a late staining, in contrast to the melanoma, where dual circulation was seen, is not seen here that typically. Lastly, we come to exudative retinal detachment in idiopathic uveal effusion syndrome. Um, you can see that clinically there's exudative detachments below with some subtle pigmentary alterations seen superiorly. But look at the angiogram where you can see that whole area, like a leopard spot pattern, areas of hyper and hypofluorescence due to extensive RP damage in that area. The fluid collects and then moves gravitationally down, and this constant whole activity, inflammation, all this keeps on creating pigmentary disturbance, and you see this classic leopard pattern, like leopard spot pattern, which you see here. When you look at the OCT, you may see fluid collections based on the level of the fluid which has come from the exudative element. If you have the patient sit up, the fluid will go down. If the patient is lying down, it may come to the center. So in today's times, we do a lot of multimodal imaging. I was talking to you through this series on the role of fluorescein angiography to a large extent. But I think today we rely a lot more on multimodal imaging. So I've showed you glimpses of fluorescein angiography, of course, being done for a lot of entities. But alongside, I've shown you the role of OCT, role of infrared imaging, role of autofluorescence, role of OCT per se. We correlate all these things, ICG also to some extent. So once you see a patient and when you're looking at a lesion, once you have multiple dimensions of imaging with you, I think it helps a lot in documenting, to confirm diagnosis, to treat these patients, and then look at, is the treatment working? Is it effective enough or not? And I think is a huge role to play for multimodal imaging. Fluorescein angiography is, I think, going to stay. We had thought earlier that maybe OCT angiography may replace it, but I think it's done it in a limited way. We still need fluorescein angiography for a lot of entities, and I think we've learned a lot from fluorescein angiography over the years, and you can see that how useful it is to diagnose so many conditions even today in our daily practice. And I hope you enjoyed hearing all sorts of cases and situations through these presentations. I'm sure there's a lot more which could have been done. There's still so many different type of cases that can come up, but in the particular time frame that we wanted to present this series, I think these four PowerPoint presentations that have come to you should include most of the common entities that you look at on a daily basis when you are looking at retinal patients. Thank you very much, and I would like to thank VRSI for giving me this opportunity to share my experience of fluorescein angiography with you, and also would like to thank my co-author, Dr. Shraddha Srivastava, who's helped me collate all these images put together, and a lot of my fellows and optometrists who helped capture over the years so many pictures and of patients. And from that collection, we've been able to put these presentations together. Thank you very much.